Welcome everyone to LBCA's Advocate Chat, How We Know What We Know About Cancer Data. I'm Lori Hutchison, an ILC patient advocate and executive director of the Lobular Breast Cancer Alliance. And it's our great pleasure to have Dr. Nadia Howlader of the National Cancer Institute Data Analytics Branch of the Surveillance Research Program speaking with us today about the SEER breast cancer data. Dr. Howlader will provide an overview of how cancer data is collected in the U.S., what it can tell us about breast cancer and lobular breast cancer, who uses the data, how it's used, and tools that are available to make the data public. After her presentation, we expect to have about a half hour for your questions. You should feel free while you listen to the presentation to put questions into the chat box. And also, as was just noted, we're recording the presentation, but we will not record the question and answer. And all participants will be muted through the presentation. And now I'd like to introduce our speaker. We are so fortunate to have Dr. Nadia Howlader with us today. We could not think of a more perfect person to speak with us about the SEER breast cancer data. Dr. Howlader is a program director and cancer epidemiologist in the data analytics branch of the NCI Surveillance Research Program. She has nearly 2 decades of experience working on clinical studies, cancer epidemiology, and population statistics and modeling. In this role, she has been applying innovative analytic tools and leading congressionally mandated reports on the national cancer burden. She utilizes diverse data systems, including the SEER cancer registries, death certificates, Medicare claims, healthcare provider, and lab data to address high-impact research questions. She also leads NCI's efforts to harmonize data systems, create new data elements, and validate these new data sources to enhance SEER registry data. Additionally, as program director, Dr. Howlader manages NCI grant portfolios in cancer surveillance, health disparities, and biostatistical methods. She also performs her own research on breast cancer, non-Hodgkin lymphoma, and lung cancer occurrences and outcomes. Welcome, Dr. Howlader.
Thank you so much for the invitation and the kind introduction, Lori. Thank you, everybody, for your time and attention. So I'm going to try and pull up the slides and maybe give me a thumbs up if you see it. And it's okay, great. So today I'm going to spend some time talking about cancer surveillance, the SEER registries, and some of the resources that we currently have available for the extramural community of researchers and also advocacy groups like yours, and talk a little bit of some of the current challenges we have with our registry data system and some of the future directions where we are headed, which I think you might find it very useful. So here is an outline of my talk. I'm going to start with a brief introduction to SEER, show you some clinically relevant data that we present and analyze. And then I'm going to talk a little bit about some of the, still we have some data gaps with our current registries and what we are trying to do to fill those gaps. So in case you don't know too much about SEER, the SEER mission is to support research on diagnosis, treatment, and outcomes of cancer. And we have been doing it since 1973. We also provide baseline data on cancer for the US population on cancer incidence and survival trends. These are population-based cancer registries representing about half of US population right now. So as you could see, every year we get information on cancer patients. Over like 850,000 incident cancer cases are reported to our registries every year, based on which we make our publicly available data set available to researchers and some reports. So the data that we receive are of very high quality. Data quality actually is a very important and integral part of the data that we curate and get in our database. And it's a very, very reliable resource for cancer statistics. So there is an organization called North American Association of Central Cancer Registries. It stands for NACER. So this organization pretty much issues certification for data quality for the cancer registry data. When they're putting out the certification, basically they say if a registry has gold, silver, or platinum level of data, and oftentimes SEER registries often come out as the gold standard. And when they're putting out the quality matrix, they're considering a whole host of things. I'm going to give you 2 or 3 examples of what they're considering, but there is a sort of a check box of items that they go through to look at what is important and has those been addressed. So for example, in order to get high quality sort of stamp, the registries have to have pretty complete case ascertainment, so 95% or higher, because we want to be able to identify these cases and follow them over to get information whether they're alive or dead. We would like to see very few cases coming from the death certificate data. That means, they have already deceased and we can't really have a lot of rich information on them. We also don't want too many missing data. So registries get dinged if they're reporting a lot of missing information. So for example, this year, because we get data on such a high volume of cases every year, there is a lag between diagnosis and reporting year for the cancer. So for example, this year, data was released on April 15 on 2022. So April 15, we put out this publicly available data set. So if you backtrack it a little bit, you'll see that the latest year of diagnosis cases we have in the file is 2019. So there is a 3-year lag between the recent diagnosis year period and the reporting period. And then typically the NCI SEER program receives the data from the registries in November, and we spend November to April basically cleaning the data, curating the data, and then putting out the data set for researchers, as well as putting out some reports. Here, I'm showing you a map with the SEER registries on it. So the dark blue color here on the map represents core registries. So these are the ones who report the data to us. And I just wanted to mention that we get de-identified data. So one wouldn't be able to link it back to the registry. They're stripped off of all the personal identification information. So it's only given to us for research purposes. So going back to this map, so the dark blue represents the core registries and the light blue represents the research support registries. So they participate in special projects. I also wanted to mention that the areas where SEER registries are not shown, there is a cancer registry for that specific state. It's just not funded by the NCI SEER program. It's actually funded by a different program supported by the CDC. So in essence, US, all of 50 states in US have a central cancer registries that are supported by either the NCI SEER program or the CDC's program. SEER has evolved over time. So when we first started around the 1970s, we started with 9 registries, and it used to cover about shy of 10% of the US population. And then we added some more registries in 1992 that brought up the coverage to 13%. And then again, we expanded in 2000, and that brought up the coverage to about 1/4 of the population. And then recently, as of June of 2021, SEER expanded again. And with this new expansion, we now cover about half of the US population and represent over 850,000 incident cases reported to us annually. And I wanted to show you this graph of percent of population covered by race by different registries. So if you look at SEER-21, which is the largest sort of the coverage we have right now, what I wanted to draw your attention is to the Asian population and the American Indian population. So with the SEER-21 expansion, now we cover almost half of the American Indian Alaska Native population and more than 57% of the Asian population. So for these minority groups, actually, SEER provides a very robust and rich source of data to study risk of cancer among these minority populations. And here I'm showing you how SEER compares to the US in terms of some basic information. Sort of, you could see that SEER covers cases that have slightly more, the population of SEER seems to have slightly more foreign-born than US-born cases, and is slightly more educated compared to the US population. But in terms of SES, they are very similar. And the types of data we have in the registries, I'm trying to give you a lot of information in terms of like the buckets of information we have. So in terms of demographics for cancer patients in SEER, we have a lot of information on age and gender, where they live at the time of diagnosis, their race, ethnicity, their insurance status, and marital status. In terms of their actual cancer diagnosis, we have a lot of information. For example, the primary cancer site, what type of, histologic type they had, the stage at diagnosis, lab values or tumor markers. In terms of treatment, SEER currently has treatment on initial course of therapy. Also, we are trying to do a lot of work right now to get more longitudinal treatment information. I'll talk about that in a minute, but we do have information on first course of chemotherapy, what type of surgery they had, and types of radiation therapy. Right now, SEER links the cases with death certificate data and other types of records to annually to see whether a cancer patient is alive or dead, and can provide information about their cause of death, which allows us to calculate some of the survival statistics. We are actually currently doing a lot of work to try to get information on recurrence, like whether their cancer has come back or not, but I'll talk about that a little bit later in my presentation. And SEER also doesn't have individual level of socioeconomic status, but the registries link at the county level with census data and provides indicator for socioeconomic variables at the county level, like at the time of your diagnosis, were you living in a poor county or were you living in an urban county? So there is a lot of rich set of information at the county level. And all of this data is sort of consolidated and available for analysis in a tool that we provide called SEER-STAT. So as I was mentioning earlier, we are moving forward to collect more clinically relevant tumor markers for SEER. So for example, I guess this group is interested in breast cancer. So for breast cancer, we have collected information on their hormone status like ER, PR, or HER2 status, histologic type, and whether they had Oncotype DX test done or not. And then these are some other cancer types for which we have other lab marker or tumor marker information in case you're interested. And some of the places here I'm showing you, I'm giving you the URL link for where we have like already calculated statistics for you. So you could go in, click on, say, SEER Explorer is one of our, so it's the third link here, has a lot of pre-calculated statistics for, say, breast cancer and other cancer, and you could play with it. We also have fact sheets that we put out for people who are not may not have a lot of comfort with very like heavy duty statistics, but want to get still some basic information about a particular cancer, we try to write it in a very plain language to help them understand these key statistics. And then we have a very nice tool called the State Cancer Profile, where you could look at a particular geographic location if you're interested in, to see how their risk is compared to like other states or by some other attributes. And then here is the last one is the annual report to the nation. It's a very large publication we put out summarizing annual updates on cancer incidence, mortality, and other trends from the US in collaboration with some of our like sister agencies. So we collaborate with like CDC, as I said, who has those other states that they cover, American Cancer Society, NACER, and we put out national statistics based on pretty much as close as possible to 100% of the US population. So I would definitely recommend for anybody to look up that report if interested. And just wanted to mention that if you are interested in actually downloading the SEER research data and playing with it yourself, it's actually very easy to get access to. All you have to do is go to this URL, and you could just basically check off a box saying you're interested and sign a data user agreement. And you could download SEER Stat, which will download the data set for you, and then you could play with it in your laptop, like pretty much within 24 hours. So we try and make it as accessible and as easy for people to access our databases. I just wanted to give you a little bit of flavor of some of the standard statistics that we report using SEER data. So a very common statistics we report are the incidence rates per 100,000 population. And then we also present trends in incidence, which we summarize using annual % change in rates over a specified time frame. And I'll kind of walk you through that so you have a sense about what we mean by that. And then we also report prevalence of people alive with a previous diagnosis of cancer. And then, as I said, because we link our cases with the death certificate and other types of vital records, we could actually calculate a 5-year probability of surviving from, say, breast cancer. And I'm going to show you some estimates based on those. And the final statistics we report is the probability of developing or dying of cancer over a lifetime or some span of time. So these are sort of the five, I call it the five statistics, like the 5 main types of statistics that gets reported out of SEER data. And here is a typical graph that we show using SEER incidence data. So here I'm showing you all cancer sites combined based on SEER 9 data. So it goes from all the way 1975 through, as I said, for our latest year, we have diagnosis information up to 2019. And you could see that these incidence rates are shown for females in the blue and for males in the green. And then these are the dots. So the triangles are the incidence rates. And then we have these lines, which are basically some slopes, kind of trying to characterize what are happening with these incidence rates over time. And for example, if you wanted to come and ask me, okay, in the recent 5-year, has the incidence gone up or down for males or for females? I would draw a line here and I would calculate this annual % change. So for males, it's shown as minus 0.2. So that means that in the recent 5-year for men, like incidence rates for all cancer sites combined has been declining at minus 0.2% annually from 2015 through 2019. For females, the slope is actually 0. That means it's flat. So that means incidence rates for females for all cancer sites combined is neither increasing nor decreasing, it's just plateaued out. And then I don't know, for fun, does anybody have any idea about this, like this green peak and then coming down in the 80s for men, like what may have driven that? I don't know if anybody wanted to think about it, but it actually was the introduction to PSA and bringing in for prostate cancer screening. So that sort of came in and made this huge peak in prostate cancer rates, which has obviously affects the all cancer combined rates. And then once the PSA sort of screening came and sort of has leveled up, you can see the incidence also picking up and then leveling off. And then we could also look at sort of these sort of eagle plots to see, okay, for which cancer sites, for which cancer incidence, which cancer incidents are going up or down among men or women. And you could see that, so this panel is for the men, and this panel is for women. And you could see that for men, like liver and melanoma and thyroid cancer incidents are on the rise. And you could see that for female, liver, melanoma, and myeloma are on the rise. And you could ask and see, okay, which cancer are going down the fastest among women, for example. Then you could see that ovarian cancer, lung cancer, and colon cancer are the three fastest declining cancer among women. So these plots and these statistics are kind of useful to kind of look at and get a sort of a bird's eye view of what's happening in terms of cancer incidence landscape. And similarly, oops, I'm not able to, okay, there you go. I was able to progress my slide. And similarly, you could look at, we also get the death certificate data for cancer mortality. So you could also see, okay, in terms of mortality, where are we seeing some improvements? So for women, if you wanted to see, okay, which cancer sites are declining the fastest in terms of mortality, you could see that melanoma, lung, and non-Hodgkin lymphoma are the top three. And the three cancer sites in terms of mortality where we haven't seen a lot of progress because death rates from those three cancer sites are going up are corpus, oral cavity, and liver among women. So these graphs are very useful to sort of get a snapshot of what's happening in terms of incidence and death rates. And as I mentioned earlier, we also calculate prevalence of people alive with a previous diagnosis of cancer. So for example, we have some information about estimated number of cancer survivors here on this slide from the 1970s all the way up to recent time periods. And the red bars are actually the projected ones, because as you saw, like the recent year of data we have is 2019. So beyond that, if we want some information, we have to project it out. So if you pick a point here, so for example, 2016, we had about 15.3 million cancer survivors in the US. And you could also look at these numbers for breast cancer or other cancers if you're interested. And then here we can show you that, okay, among the some 14, 15 million survivors, what are the like the two top cancer sites? You could see that these are breast and then followed by prostate, and then you have other cancer representations as well. Also, SEER data, just because we have such a large proportion of the population we cover for minorities, is a very rich source of data set to study disparity. So for example, here I'm showing you a graph of liver cancer incidence by 5 main race ethnic group and the liver cancer mortality. And for the race ethnic group right now, I'm looking at whites, blacks, Asian Pacific Islanders, American Indian, Alaska Native, and Hispanics. And you could see that in terms of incidence, liver cancer rates are the highest among the Asian population. And actually it's rising for other groups too, but the second highest is among the AIANs. And in terms of mortality, one could also see that even though the mortality rates are for liver cancers are sort of in a decline for Asian population. It's actually in the rise for all the other cancer subpopulations. And here's a graph I have for breast cancer. As you already know, that breast cancer is the highest among white women in terms of diagnosis, followed by Black women. But if you look at mortality, you see the opposite picture. So mortality, breast cancer mortality is the highest among Black women compared to the white women. So one question, obviously, we want to understand better is why such disparity? So one of the ways we could look at is through more clinically relevant data presentation and analysis, particularly for breast cancer. We know that breast cancer is not a single disease. It's a collection of many subtypes of breast cancer approximated by their tumor markers. So using SEER data, what we are doing is we are looking at the hormone receptor markers, which are represented by ER and PR status. And then we could also look at HER2 status. And using these three markers, we can subdivide the breast cancer into like the molecular subtypes, right? Approximated by these four categories like luminal A, luminal B, HER2 enriched, triple negative. And what we have found in our data set, when we did this calculation, that here is a graph of incidence rates of breast cancer by molecular subtype by age groups. So the ages are on the x-axis and rates are on the y-axis, and we are showing it among four main race groups like non-Hispanic white, non-Hispanic Black, non-Hispanic Asian Pacific Islander, and Hispanic. If you look at the, if you look at the hormone receptor positive, HER2 negative, or the luminal A group, which is the most treatable breast cancer subtype, highest rates are among white women. But if you contrast that subtype to triple negative, you see that triple negative in Black women is the highest compared to any other subgroups. So perhaps that disparity that we saw earlier also, I mean, I'm sure a lot of things contribute to it, access and screening, but also the fact that breast cancer, triple negative subtype, which is very hard to treat, are more prevalent among Black women than other subgroups, perhaps also kind of contributes to that disparity among many other factors. So if you want to learn more about some of the statistics, we have published some papers on it, and we also in our website allows people to go in and get some of these finer subtype data by race and age and some other factors. So you're welcome to go play with that. So these are two references I put there for those who are more interested in learning about these subtypes. We also looked at some of the survival information by molecular subtype. So here is a breast cancer survival statistics from months since diagnosis. So, you know, like 12 months out, like 1 year after diagnosis, 2 years after diagnosis, 3 years after diagnosis, and 4 years after diagnosis by the subtypes. And again, as you probably know, hormone receptor positive, HER2 negative has the best prognosis, followed by triple negative subtype, which is, again, is not so easy to treat, and hence the prognosis looks terrible. And then we had some missing data with the tumor marker. So we also put the unknown subtype here, but then we use some statistical imputation algorithm to fill in the missing data. And then we recalculated these survival curves, and we found that they still matched up pretty nicely. And here is, again, the information on survival by stage at diagnosis, like whether you were diagnosed at early stage, like stage 1 or 2, versus late stage, like stage 4. And what is, again, is sort of, probably people know it, but this data is very striking, is that if you are diagnosed with stage 1, I mean, regardless of your subtype, you have a pretty good outlook in terms of, survival probability 4 or 5 years after diagnosis, like almost close to over 90%. If you're diagnosed stage 4, even if you get a very good subtype, your prognosis start to look more grim. So again, this data could be very informative in kind of thinking about sort of prognosis, and also being able to also use, like, knowing this data and talking to your physicians about, like, what are the treatment choices, and just learning that there are, like, different subtypes, and having some conversation would be very useful. And again, this paper sort of has some of this information, again, for those of you who are more interested in learning more about these statistics. I want to talk a little bit about some of the challenges and opportunities we have right now with the registry. So far I've sort of talked a little bit about data, how you access it, some of the statistics we put out there, how you sort of look at them, get a sense about them. But our registries right now are great and a wonderful resource for the researchers and the community out there, but it has a lot of challenges still. So for example, here is a sort of a line that shows currently what SEER has. So SEER has a lot of rich set of information on cancer at the time of cancer diagnosis. So you have this big sort of circle here filled in, and then we follow people up, and we kind of know at given one point in time after diagnosis whether somebody's alive or not from their cancer. So we also, that circle is also filled in. But the in-between points, so for example, after you get diagnosed, what type of treatments are you getting? We have initial course of therapy, but we don't really have longitudinal or subsequent course of therapy. So that's a big data gap we have here. We also don't have, unfortunately, a lot of information whether cancer comes back or not on people, so the recurrence status. So there's a data gap there. So right now we're doing a lot of work trying to fill in this data gap. In terms of outcome also, besides recurrence, we don't have information on patient-generated health outcomes or side effects of some of the therapies that they go through. So the other challenge we have right now is a lot of the data are manually processed. And as you know, US has an aging population, and with that, a lot of cancer cases are being diagnosed now and in the future. So trying to do this manual abstraction of data would be very hard to keep up. So we are trying to figure out what other modern technology we could bring in to abstract this data. So right now we have a few strategic initiatives underway to sort of enhance our surveillance infrastructure. We have put out some program announcements where we are asking and soliciting applications from researchers, academic people in cancer center to sort of tackle some of these difficult data gaps by either linking with other data sources or manually, or coming up with some algorithms to fill in this data gap in terms of recurrence and detailed treatment information. So we have a couple of projects that are promising right now that are underway. So hopefully we would be able to put out some information on cancer recurrence in the next couple of years. There was actually a paper looking at breast cancer recurrence, putting out some estimates about what proportion of women breast cancer recurs, and kind of giving those estimates by age and by subtypes. So if people are interested in this webinar group, I can share that paper. So that was done based on some algorithm like derivation, but we are actually right now doing a lot of work curating different types of medical records to get that information and have it part of our database. It's not available right now, but it's something we hope to have maybe in the next foreseeable future, 2-3 years down the line. So ultimately, we are trying to position our cancer registries not to support research as is right now, but also to support the next generation of cancer research by populating some of these data gaps, addressing technological issues, etc. So I think with that, maybe I stop here, and I want to thank you for your time. And here's my email. If you have any question, I'll be happy to get back to you.